Welcome to St. Joseph's University's Unlimited Learning Series, Telehealth, Expanding the Access to Care, with Assistant Professor in the Department of Health Studies, Dr. Thomas Martin, and St. Joseph's University's board member, Dr. Peter R. Kowey from the class of 1971. I'm Emily Advani from the class of 2007 and Master's Class 2008, and I have the distinct pleasure of hosting today's event. First and foremost, we hope everyone and their loved ones are well. Also, a shout out to all of our frontline workers and essential workers who are keeping us safe and healthy during this uncertain time. We will be forever indebted to you for your sacrifice and service. Thank you to St. Joseph's University for coordinating today's event. A key element of the St. Joseph's University mission is the commitment to lifelong learning. In this spirit, SJU is offering the Unlimited Learning Series, an opportunity for lifelong learners to engage with university experts and content through virtual events. I'd also like to introduce St. Joseph's University's Megan Burke, who will be assisting behind the scenes with poll questions and Q&A. Throughout the session, we encourage attendees to submit questions via the Q&A feature. Please include your name, location, and graduation year if you are an alumnus. And speaking of polls, before we jump in, we welcome attendees to take part in our first poll question that will pop up on your screen. This is our first poll. Are you attending the webinar as a patient or healthcare provider? Now, thank you to Dr. Martin and Dr. Kowey for lending their insights and expertise to this timely topic. Dr. Martin has more than 10 years of experience in healthcare and has experience in the telecommunications and healthcare IT industries. Dr. Martin began his journey in healthcare working at the Cleveland Clinic Foundation. He has served as a project lead for numerous IT implementations and mobile app developments and is a former director with Healthcare Information and Management Systems Society, a global cause-based not-for-profit organization focused on better health through information technology. Dr. Kowey joined the Board of Trustees of St. Joseph's University in 2015. With nearly 40 years of experience in healthcare, Dr. Kowey continues to practice medicine, conduct research, teach medical school students, fellows, and physicians in practice, and provides industry consulting and consulting to the FDA. He founded and directed the Mainline Health Heart Center and the Lankenau Heart Institute. Dr. Kowey is the William Wyckoff Smith Chair in Cardiovascular Research at the Lankenau Institute for Medical Research and a professor of medicine and clinical pharmacology at Jefferson Medical College. Welcome to you both.
Thank you so much for having us.
Thanks, Emily. Nice to be here. Thank you.
Wonderful. Now let's see those poll results. Okay. It looks like we have 22% of our attendees today are hands-on healthcare professionals. 19% are working in healthcare management. 41% our biggest group, not in the healthcare industry, but may take advantage of telehealth as a patient. And another 20% don't fall into these categories. So a wide range of attendees today. Thank you for being here. Now, Dr. Martin, I'm going to turn it over to you. To our attendees, once Dr. Martin shares his presentation, go ahead and change your screen view to side by side for the best experience. Also, please note that we will make these slides available following today's webinar. Dr. Martin.
Thanks so much, Emily, for the introduction. Dr. Kowey, thank you for your service, front lines of this tremendous challenge that we're facing as a nation. I wanted to go through just a couple of slides. Again, we've got a wide range of individuals joining the call, so it might be helpful to just provide a little bit of background. One of the things I thought would be useful would to sort of couch our approach to telehealth here as it relates to some of the guidelines that we've seen, which are stay at home, stay safe, save lives. Having worked in a radiology department for several years, we always talked about time distance shielding in radiology, and I think telehealth is one of the ways that we can use technology to help us achieve and maintain some of these guidelines, which are still in place. In terms of staying home, not just Mainline Health, but several healthcare providers in the region are expanding their telehealth capabilities. You've probably seen the advertisements, the commercials on TV from insurance companies urging individuals to use telehealth. And I think the fact that we've got over 40% of individuals here as sort of patients really speaks to that. In terms of staying safe, calling your primary care provider, trying to seek care remotely continues to be a best practice, as well as physical distancing. We do have a couple of both efforts here within St. Joseph's, as well as programs and courses that help our students understand and become better prepared to help support healthcare professionals on the front lines using telehealth. This past fall, 2019, we established the School of Health Studies and Education. We also have programs in health administration, health education, as well as pharmaceutical and healthcare marketing across various schools here at St. Joe's. And of course, I teach HAD 561. We really go into the nuance of how to prepare administrators, management professionals to conduct telehealth. What's the difference between a synchronous engagement, like many of us are having right now, versus an asynchronous engagement? Somebody might access this recording afterwards. So we try to provide students a bit of background in the terminology and approaches in a very wide sort of technological landscape, a very sort of nuanced field of healthcare. You're probably wondering, or perhaps the 40% of you who are coming to this webinar as sort of patients, you've probably been wondering, well, why haven't we been doing this 6 months ago, 8 months ago? Why the sudden shift? And there are several professional groups, there are several entities out there that have been working for several years, if not decades, to try to increase patients' access to telehealth services. There are a number of state and policies that need to be adhered to that have kept us from allowing healthcare professionals to practice across state lines. While the federal government shapes healthcare policy broadly, they oversee Medicare and Medicaid, states are often left to ensure that medical professionals within their location are appropriately credentialed. So we needed to update or introduce legislation that would allow practitioners like Dr. Kowey to sort of practice into Delaware or New Jersey or Maryland. We've also had challenges with payments. It's very difficult to sort of come up with what is the value of someone reading digital health information coming from an Apple Watch. I actually forgot to put mine on today, but that's a very sort of new, recent development where we now have basically clinical grade ECGs on our Apple Watches and many other smartwatches that are out there. Also, historically, we focused on connecting healthcare professionals to individuals in urban region or rural regions. So we call it the hub and spoke model. You know, we're here in Philadelphia, we have a wealth of healthcare professionals in our region, but as you go further northeast or further northwest in the state of Pennsylvania, it becomes very rural, very quick. And most of the policy has focused on connecting those two geographic locations. Because of COVID-19, we're now in a setting where it's no longer that convenient or that possible to make your way into the city or to drive 15, 20 minutes, and it actually places individuals at risk. We've also had the exclusion of certain technologies for services rendered. If I were to say everybody would be at home using pulse oximeters a year ago and reporting that information into our healthcare system, a lot of people probably would have laughed at us. But here we are with a shortage of pulse oximeters on the shelves and more patients looking to connected devices, whether they're thermometers, whether they're pulse oximeters, to help take care of themselves. Dr. Kowey, anything you wanted to sort of add on this?
Well, first of all, you're doing a great job, Tom, in covering a complicated topic, but several things that you said are extraordinarily important. This territorial jurisdiction issue, first of all, let me just back up a minute. What's happened, obviously, with telemedicine is that we're implementing it on a relatively short timeline. Nobody really anticipated having this need right away. And over the course of just under 2 months, we basically have tried to implement it across a very broad spectrum of patients and geographies. So this thing about the state line issue has come up, and in fact, we are restricted, and there are about, I think, 6 states now that we can practice telemedicine safely without any concerns. But there are a number of state jurisdictions where we're not really supposed to be doing it yet. I suspect that will change pretty rapidly, but right now we are restricted. You mentioned the payment issue. There's been different policies issued by various insurers. In fact, as we were just talking a few minutes ago, Medicare just over this past weekend decided to allow audio-only telemedicine visits to get reimbursed. We were facing a situation with Medicare patients. These are elderly patients who are not necessarily tech savvy, where they needed to get on a screen before we would be able to bill for a telemedicine visit, which is obviously not going to work out real well. And then another point you made that is extraordinarily important is this idea of using technology at home. The Apple Watch is probably one of the most outstanding examples of that technology, but we're getting now to the point where we can monitor lots of other physiologic parameters by telephone and by computer. So the landscape is changing very, very rapidly, but I think in a very positive direction. And I'm very grateful to our government people who've been working very hard with trying to get this taken care of, and our insurance carriers trying to reach out and do the best we can for our patients.
Excellent, thanks. And I think you're spot on. There's so many different types of insurance out there: Medicare, Medicaid at the federal level, and then the various private insurers that are out there. And all of those entities are going to approach telehealth in a very different way. We had another poll that we wanted to put up on the screen to sort of get your feedback in terms of next steps for the next 2 slides that we've got. Emily, you want to take it from here?
Sure. So poll number 2, which of the following best describes your attitude about telehealth, either as a patient or a practitioner? And I see the results coming in, and it looks like just out of the gate, we have a majority of our attendees who are excited. I am open to new options for healthcare at 83%. We have another group, a smaller subset, toggling back between maybe 15 to 16%. Skeptical. I have many questions and concerns that need to be addressed before I would try it. And right now, we don't have anybody who said critical. I have doubts about telehealth and I'm unlikely to use it. So it looks like the vast majority of our participants at 85% are said, I'm open to these new options for medical care.
That's great. And, one of the questions that speakers always ask is who's going to be my audience? And I think Dr. Kowey and I, coming into this, we weren't really sure if we were going to be speaking only to patients or only to healthcare professionals that were just interested in sort of the nuance of telehealth. So we saw this coming and we decided to do 2 different slides. One really looks at from a patient perspective. So if you're in that early 40% of individuals who are patients, hopefully the next slide here provides you a little bit of information on what you might be able to expect from your perspective, whether you're excited or a little bit skeptical. Again, you've probably heard the saying over and over again, which is call your primary medical professional first. It's really sort of fascinating for me to think about our emergency rooms being largely empty as individuals are seeking more and more telehealth types of encounters. And I often in class, I ask my students, how did you educate yourself on how to use our healthcare system appropriately? And more often than not, right, it's always, well, I had to go get shots. My parents took me, and that's how I learned to utilize our healthcare system. And there were questions that were submitted in the run-up to this around utilization that I think we'll get to in the question or answer period. Some of the other things that you might want to consider, you might want to, if you can, and if you have a smartphone and you're somewhat technology savvy, or you're maybe close to your grandkids or your kids, and they can help you a little bit, download the mobile application for your health system or practice group. There's a wealth of technologies and approaches that your healthcare professional organization can deploy through that mobile application. A couple of other things to be aware of. You might be referred to another healthcare provider within the practice group. You've probably heard a couple of really unique stock tips around Teledoc or American Well, which are large services that provide additional capacity and support to healthcare professional settings to conduct these types of interactions. If you're not really sure who the medical professional is that you're seeking, you should do a little bit of research on them. There's several almost Yelp-like offerings out there on the internet that allow you to do some background information on the healthcare provider you'll be seeing. And I think Dr. Kowey mentioned this a little bit in terms of location, where a healthcare provider might be able to practice into. You're going to have your medical professional announce the location that you're coming from. So Emily did a great job of exhibiting this in the welcome to everybody, right? She announced the time of day, what hour it was, what month it was. And I should let you all know that I'm coming from my home office in Chadsworth, Pennsylvania. But you should expect your healthcare provider to announce their location, where they are, and they're most likely going to ask you your location. Again, because of those state restrictions, if you were to jump on the phone with Dr. Kowey and say, well, gosh, he's in Pennsylvania, you're in Florida, he might say, listen, we can't go any further because of restrictions on my license or the ability to practice into that specific state. So get comfortable with announcing your location, the time of day, where you are, all of that. Also, avoid services that are really too good to be true. Fraud and abuse was a terrible problem before COVID-19, and instances like this only exacerbate instances of fraud and abuse. The last thing that I want to point out is that you should request access to the documents or the summary of care documentation that your healthcare provider would conduct for you. As a legal right, you may or may not have heard about HIPAA. You've probably signed forms for the 40% that are very familiar or excited about telehealth. You've probably signed waivers around sharing of your information. You also have a legal right to access that information, and being able to get that back after your telehealth visit can be really important in terms of next steps. Dr. Kowey, anything you wanted to add here?
You're making my job real easy, Tom, because you're covering really the salient issues and doing it so well, as you always do. But it's kind of fun just to pitch in a few things that are worth emphasizing. One is that going through your primary care doctor or the doctor that you're familiar with, your primary cardiologist, for example, is really the best tactic. Don't go out and look for docs on the internet. Don't cold call offices, because it's just not going to work out really well. The only reason that telemedicine really works well in our practice is that we're prepared. We go through the charts. We know the patients well. So we're going to, in a relatively short period of time of 10 or 15 minutes, we're going to hit on the most important issues that the patient has, and we don't need to go back through an extensive history, for example. We occasionally will see a referral from our own group within group practice, but then again, we have those records ahead of time, and the whole thing is much easier that way. And you have the assurance that you're dealing with somebody that you're comfortable with. So that's a very important principle. Another thing that you said that I think is extraordinarily important is that people really need to get information out of the visit. And, these visits are very anxiety provoking for patients. So many times patients really don't remember everything that we say. So we really try to give the patient some kind of an enduring summary of the visit. You can certainly have anything you want out of the visit. You can go all the way down to the details of every test that you had. I have to say that after doing this for a very long period of time, trying to look at the source documents, the actual reports, for example, from an echocardiogram or from an EKG, can be very confusing to patients. So what I try to do is filter it so that the most important information comes to you. But you have it in some kind of a form you can put in a file or put on the web somewhere so that you have it in at your disposal. That's very, very important. But the most important thing, and Tom, you said this as well, is you need to come away from the visit feeling confident. The telemedicine visits, to me, one of the most important components of the telemedicine visit is psychological. It's psychologically connecting with your doctor and feeling confident that you have a path forward and that you're going to be okay, that you don't need to worry, that you don't need to run into the emergency department, that you don't have to fret. You have enough to worry about. There's enough stress in our environment. Our job is to take the medical care stress off of you as best we can. So before you get off the phone, ask all the questions you have to answer, and make sure that, by the way, another thing that happens during those visits is the spouse jumps on the call. Make sure that everybody that's on the call is satisfied with the information and feels confident going forward. That's very, very important.
Yeah, and remembering my clinical days a long, long time ago, they can often be a very valuable member of that care team as well.
Well, there's some docs that don't even have anything to do with unless the spouse is in the room, because they're the ones that rat out the patient, right? I mean, oh yeah, I'm doing just fine, haven't had chest pain in months, and the spouse is over there shaking his or her head, going, I don't know about that. So they're very, very valuable people.
We also wanted to, hopefully that walks you through at least some of the things. I think Dr. Kowey, just to go back to one of the comments that he made, the too good to be true. Prior to COVID-19, there were several $49.99. You can have a virtual visit with any healthcare provider. I think now more than ever is a time to consider not going down that pathway. But if you do go down that pathway, or you have to go down that one-off, you might be an individual who does not have an existing relationship with a primary care professional. Make sure that you get those documentations, and that maybe after this passes, you endear or endeavor to have a primary care provider. We also wanted to provide some resources or highlight some resources for those of you who might be coming to us from a healthcare organization professional, or you might be a frontlines clinician, to give you a sense of where you could turn to for trusted and valuable resources. And we've already touched on the mishmash or the hodgepodge of state policies that are out there in place. And so if you're coming to us from Delaware, New Jersey, Pennsylvania, Maryland, or beyond, there are some really great resources out there that can help organizations navigate establishing their telehealth practices. The first one that I'll highlight is the Center for Connected Health Policy. They are an AHRQ funded entity. They're a federal government entity, basically, and they have done a tremendous job of tracking a couple of issues that we've seen in the questions around payment parity, around interstate licensure, around the difference between physical therapy professionals, nurses, physicians, the ability to practice across state lines. And they're sort of a more national entity. For those of us who are here in sort of the Maryland, Delaware, PA region, you may or may not be familiar with the Mid-Atlantic Telehealth Resource Center. Also a AHRQ HRSA funded entity that receives federal funds, that has a mission to deliver value to those within their constituency or within that region. They're a really great resource as well. I think in terms of healthcare organizations, what to think about, obviously protocol, following whatever your most current practice guidelines are for conducting telehealth visits. In terms of documentation, we use CPT, which is common procedural terms. So it's really sort of the language of what happens in the background around a healthcare encounter. Back in September, the American Medical Association, the CPT editorial board, they introduced about 6 new CPT codes that allow us to hopefully better quantify a reading off of a smartwatch that maybe goes back to a cardiologist or an electrophysiologist to sort of get our hands around what that encounter looks like. In terms of payments, again, every insurer is going to approach things differently, whether they're private insurance like an Aetna or a Cigna or a Blue Cross Blue Shield versus federal funds, Medicare and Medicaid. Several states have acted very quickly. Medicaid is very flexible in terms of the benefits that are provided to the individuals within that state. And as a result of this crisis, several states have gone and revisited their plan, and they've submitted updates or an amendment to that state plan that would allow for an increase in telehealth services. And then last, on the privacy side of things, the Office of Civil Rights within Health and Human Services has provided a notification of enforcement discretion, which is the fact that we're dealing with a pandemic right now, that there's going to be a little bit of leeway on the privacy and security front. But again, a best practice would be to use recommended or a technology service that's provided by your healthcare organization, whether it's Skype for Business. There's several, Dr. Kowey mentioned Doximity. There's several other encrypted platforms that can be deployed to help deliver telehealth in a secure setting. Dr. Kowey, anything else you wanted to add on this?
Again, a couple of points to emphasize. Yeah, we struggle with the privacy issue, especially since we're trying very quickly to move to these platforms. We're actually working on, at our place, we're using Zoom primarily, and so far it's been going pretty well in preserving some of the firewalls. Going in both directions, by the way. Not only, remember, the privacy isn't just the patients, it's also the providers. So not getting into situations where the provider's private information is being exposed either. So it works both ways. The payment issue is very complicated. You know, I said to my practice administrator this morning, I rarely even looked up at the banner at the top of the EMR as to what kind of insurance people had. It didn't matter to me. You know, I go see a patient, you know, I see a patient, and I don't really care what kind of insurance. I just, you know, the bills are the bills. If they pay them, fine. If they don't, well, that's the way it is. Now I can't go there anymore because I need to know whether I bill a telemedicine visit or a virtual visit or an audio visual, blah, blah, blah. So it actually makes me sad that I have to worry about that stuff, but I do, and we have to be pragmatic about it. And then the final point is, and I know that we're going to get into a couple of questions on this, is the medical legal implications. A lot of people now are doing things that we never thought we would be doing. People are coming out of roles. We have people who used to work in our offices or are now working over in the hospital, taking care of very sick patients. So people are stretching their skill sets. There's going to be more mistakes. And what we're hoping is that the government, both at the state and the federal level, do enact the proper legislation to protect people from lawsuits that might accrue from this experience. I'm not trying to say that people don't have a right to a redress of their grievances. They certainly do. But in this situation, I think everybody will agree that we have to be a little bit more pliable and flexible.
Which kind of brings us to sort of what does the landscape look like going forward. And I hate to disclose that I've been teaching from the slides since 2013. I hope there's no former students who have signed up for this webinar that say, oh yeah, I remember when he showed this slide to me 8 years ago. But I mean, the way that I think we've been seeing the opportunity within technology to do things a little bit differently within our healthcare system for quite some time. You know, the way that patients are seeking care, but before this, I would pull up a platform like ZocDoc that would allow you to quickly identify a healthcare professional that you would go see tomorrow. And sometimes I would just revolutionize a student's life by providing, you know, a referral to that platform, so to speak. But patients are seeking care in a very different way, even prior to COVID-19. And I think as we sort of look forward, we're going to see scheduling telehealth versus in-person. We're going to have to start to sift through what does it look like to bring a patient into a practice group through maybe a telehealth visit first, and then shift to face-to-face types of encounters over time. You know, patients showing up for procedures at hospitals. One of the worst things around colonoscopies is the prep. But one of the things that is the best predictor of, you know, the accuracy and the sensitivity of that test is really the prep that goes into the patient. So getting patients prepared before they come in for services is another tremendous opportunity for telehealth and remote and connected devices that are out there. Monitoring patients' long-term care. Again, I mentioned pulse oximeters. The fact that we've now got to run on pulse oximeters out there is just unfathomable to me. The ability to monitor patients longer term. Before we had the 6 CPT codes that were released back in September, there was a chronic care code 99490 where you had to have multiple comorbidities. You had to have a hospitalization within the last 30 days. You know, so there's this tremendous opportunity or inflection point right now to think about how we monitor patients going forward with technology, and then that exchange of information over time. I hate to say it, but we were in the middle of a tremendous shift in terms of how we approach technology and create things like electronic health records to make it easier to exchange information. That rule was being finalized right as this pandemic hit. But that ability to move information from location to location is something that we're continuing to work on. I would venture a guess that more EHRs are going to build in telehealth services. They were working on that before. It's going to be accelerated at this point as well. But we wanted to maybe move to questions as well.
All right, Dr. Martin and Dr. Kowey, thank you for the first part of that presentation. I'm going to jump in with a couple of broad-based questions, and I think we're all most interested in hear what our attendees are thinking and what their questions are. But from your presentation, it seems like telehealth has been something that the healthcare industry has been talking about and exploring for some time. And this COVID-19 pandemic has really thrust the industry and patients into this new frontier very quickly. I know we explored historical barriers a little bit, and I'm going to get back to those, but I can actually speak from personal experience. I'm currently 35 weeks pregnant, and my last prenatal visit was moved via in-office to a telehealth appointment to reduce the exposure of coming to the office until they deem it necessary. And I'm sure there's multiple layers here, and selfishly as a patient, but also I'm sure there's a lot of people wondering, both healthcare providers and patients, how do you begin to choose which patients, appointments, cases that you would take via telehealth, telemedicine, and which you really believe you need to see in person? And like I said, there's probably multiple layers here that are both the clinical care end of things, but also policy and procedures. But what I'll do is I'll start with you, Dr. Kowey, on sort of the practitioner end.
Well, Emily, it's a great question because it's the answer's in evolution. So as you and as Tom said so eloquently, this was all coming. There's no question. This was on the tracks, and what happened is that we accelerated it. And I, for one, I have to say that I'll admit that 2 months ago, when I first started hearing how fast people wanted to go with this, I was very skeptical. But it's amazing how well we've done with it, considering the speed, and how well we've been able to implement it, how happy our patients have been so far with most of it. I mean, there are still lots of things to iron out. But the question that you're asking is very important, and that is, going forward, how are we going to select type of visits for our patients? And I really can easily envision a mix where patients will get both kinds of visits. So for some of our visits, it'll be in person, but we have a lot of patients, for example, we follow with implanted devices. So they're automatically telemetering information constantly to us. So we've been in the practice of having those people come in every 6 months to the office, but I could actually easily see where we could extend that maybe to once a year. And in that 6-month visit, something on the phone where we just review the information that we already have. So I see this as giving us a tremendous flexibility in terms of practice. Patient situations may change. Patients may be, here's one of our classics. One of our classics are the snowbirds, right? The people who live here and go to Florida for the winter, and they feel like they're cut off, because they're in Florida for the wintertime and they don't have any access to us. So they end up seeing doctors in Florida who aren't really familiar with them, and they sometimes get into a lot of trouble doing that stuff. Well, now they're in Florida. How about a telemedicine visit? And that'll maybe just tide you over long enough so that when you come back in the spring, we can get another in-person visit. So I can see where this could really facilitate the way we take care of patients, not only in terms of making it easier for the patients, but also keeping them safer.
And Dr. Martin, do you see any policies and procedures that are sort of dictating what maybe you must do, whether you believe a patient should be seen in person or telemed?
Yeah, I think Dr. Kowey did a great job covering the clinical aspects of this. I think there's a question around the underlying technology and what's an appropriate underlying technology to use. For example, right, what we're doing right now, this sort of, in our office, in our home office type of interaction that's good for evaluation and management of patients. When you think about robots, right, and the notion of telepresence, I've seen several case studies or large healthcare networks that have leveraged telepresence, right, basically a robot with a screen and a head that allow someone like Dr. Kowey to navigate through crowded halls and get to the bedside. And so this type of interaction is very, very different from something like rounding. There's been several pieces of literature that have looked at telemedicine and intensive care units. And that is very much I hate to use the term bunker based, but it's very, 6, 7, 8 different monitors where people are continuously monitoring. When you think about having to limit distance or exposure, being able to have individuals watching monitors remotely can be very useful from a technological perspective.
And
yeah.
Go ahead.
I'm sorry. No, I want to just say that that's a very good example of how we can facilitate, especially in the current environment, how we can facilitate care. And
speaking of sort of being thrust into this, both technology, policy, as patients, as physicians, and practitioners, you in your presentation, Dr. Martin, you talked about some of the historical barriers to telemedicine and how some of those are coming down, and there's still some left to be overcome for our current situation, and then moving ahead depending on what healthcare will continue to look like. But I'm interested from both of you, what have you seen as sort of the biggest barrier that came down very quickly? Dr. Martin, if you want to speak to sort of the policy, and then Dr. Kowey, will move to you in terms of clinical practice. What really sort of flipped the switch there?
So again, when you talk about policy, it's really on a state-by-state basis. Here in the region, Delaware very quickly flipped the switch on allowing any credentialed practitioner that was in good standing in their home state to practice into certain locations. New Jersey did something very similar to that, right? Kind of the good faith, good Samaritan. If you're credentialed at a home state, other states did not do that. So, the hodgepodge or the mishmash of policies makes it very difficult to kind of grow geographically through this. Some other things that I think happened really quickly, Dr. Kowey did a good job of highlighting the changes in Medicare payment. That's happened relatively quickly as well. But again, this was a bus that was coming out of the station. We had a lot of recommendations built into it as well. Dr. Kowey, anything you wanted to?
No, I agree. It came so fast that there really wasn't any uniform approach, and we've had to deal with this hodgepodge, as you said, Tom. One of the things that happens in this kind of a situation is healthcare professionals, and you've witnessed this in spades in the last couple of months. Healthcare professionals tend to do one thing, and that is patient goes first. Okay, the most important thing is the patient. So, what does the patient need? We all knew, because we were getting bombarded with phone calls, that our patients needed telemedicine. They needed some contact with us in an organized way. And what happens, what doctors do sometimes, and I'm just as guilty as everybody else, is I say, okay, I'm going to take care of the patient. I don't really give a crap about the reimbursement. Okay, that doesn't bother me at all. I don't care if we get paid or not. Well, that's kind of stupid, because we can't run our offices without getting paid. So we were taking phone calls and doing things with patients even before the reimbursement schemes were clear, but now they're clearing up, and it's good because we are able to collect some fees, and those fees are very important because they keep our offices open, they keep the lights on, they keep our staff employed and paid, their benefits paid. So it's really good that we've come together and been able to figure out a way to get some payment for some of the things that we're doing, because we can keep the system going better that way, and it's come along pretty well, Tom. I think, even though you're right, it's been a little bit of a struggle.
Well, now, Megan, I'm going to turn it to you so we can grab some questions from our audience. I know there were a ton that came in before, and I'm sure more have come up since. Megan.
Yes, that's right. Thanks, Emily. I think we'll just start. There's a theme that I'm seeing coming through on the questions. Primarily, how do healthcare providers develop a rapport in a virtual environment? And then a second part to that is, how do you prepare patients who may have a cognitive deficit or a visual or hearing impairment?
Dr. Kowey, do you want to start with that one?
Oh yeah, they're both great questions. So one of the things that we said a little bit earlier is that telemedicine works best with familiar patients. So one of the reasons that that's true is that it is very difficult to develop a rapport over the phone. When I was in training, the guy that I trained with, who happened to be a Nobel laureate, so he was a pretty smart guy, and he said one of the things that you always have to emphasize when you're seeing a patient is touch, that you're in physical contact with the patient, and that's one of the ways that you develop a rapport. That's why the physical examination is almost like a ritual with the patient. That it's part of what the patient expects. It's part of the touching. It's part of the experience. And obviously, all that's going in telemedicine. So to try to establish a rapport is extraordinarily difficult. You can do it, and you can answer questions, but it's a relatively sterile exercise. I actually look forward to my telemedicine visits because these are my patients that I've had for a while. A lot of them I've had for many, many years. They're my friends. We're all isolated, right? It's an opportunity to talk to some buds, right? To some friends, the people that I like, men and women that I identify with, a lot of whom I went to school with, a lot of people I've known outside of the medical profession. So the rapport really isn't a big problem for me because most of the patients are familiar, and when they're not, I'm able to get over the hump at least and make sure that we have a good experience on the phone. What was the second part of the question again, Megan?
The second part was preparing patients who may have a cognitive, visual, or hearing impairment.
So another great question. In fact, I ran into it last week. I had a patient who had a very, very severe hearing impairment. And my staff saved me, okay? They saved me because they made sure that the patient knew that they had to have their spouse at the visit. So it was simple. The spouse was there. We were able to help me get the information across. You're going to have to take these on an individual basis, but you have to be prepared so that when you get on the phone with them, that there's some way to communicate, because these can be problems. I've also had a number of patients over the last month who have mild cognitive impairments, and in that situation, I do the same thing I do in the office, which is to make sure that we repeat things, that they understand things, and then, as Thomas said several times, that we have an enduring record of the visit.
Dr. Martin, anything you'd like to add to that question?
No, I mean, when I hear that, how do you develop rapport? I think it's, and we covered this a little bit in the poll as well, I think, right? People are still a little bit skeptical. And I think ensuring that when it's time for lights, camera, action, that everybody's as prepared as they can be, and that they're as knowledgeable as they can be in terms of what they are expecting to get out of the interaction.
That's great. Megan, next question from the audience.
Sure, another question that we just had come in. How do you see the need or demand for traditional annual physical exams changing with more virtual medicine visits?
Dr. Kowey, do you want to start with that one again?
I'm sure the audience, this is a sophisticated audience. The audience knows that there's a tremendous amount of controversy about the need for annual visits. Without any pre-existing medical condition, somebody that's reasonably healthy, what is the value of having an annual physical examination? Most of us believe that as you get into your 50s and 60s, it's probably not a bad idea to have a relationship with an internist, and the way to really preserve that relationship is to have a visit once in a while. Is it 1 year? Is it 2 years? It has to be something on a regular basis so that you maintain contact. And there are laboratory tests that can be done during those visits and things that can be done in the physical examination to really help people stay healthy. Those kinds of visits are very elective, and so they don't necessarily have to be in a rush. I think that we've been putting off a lot of our really routine examinations in the office because we don't really have to do them right away. How that will work out in telemedicine, I really don't know. I honestly don't think it's going to work out that well, because I think at least on some regular basis, you got to be in the room with the patient. And trying to do all of these visits by telemedicine, I think, is probably going to be futile. But again, it's going to be an individualized kind of deal, and for some patients, there may be some opportunities.
Dr. Martin, anything you'd like to add?
Yes, so I think bundled payments is a sophisticated term that I'll throw out there, but it really means that we're going to set a price for delivering a type of service. And, you know, is there a way that we could bridge a gap or allow, you know, healthcare professionals like Dr. Kowey to say, listen, I think you're pretty tech savvy, right? I don't need you to come into the office, but let me schedule this high touch continuity of care interaction with you over time. So, you know, trying to look forward a little bit. I think the ability to use telehealth interventions around bundled payments or services where the fee is really set can be quite useful.
Great. Megan, next question from the audience.
Okay. Sure. Another question that came in asks, what role do you see telehealth playing in emergency care?
Dr. Martin, do you want to start with this one, maybe from a policy perspective?
Yeah, you know, it's interesting. When I saw the term overutilization, how do we ensure we're not overutilizing this? And again, you know, we're not seeing a lot of folks going through the emergency room right now. I went out, I did a really informal poll of all of my social media followers. And I asked the question, you know, is it a good or bad thing that the emergency rooms are largely empty right now? Because we've shifted a lot of that over to telemedicine. And that's revenue stream lost in one side of things. And whenever we talk about the amount that we spend here in healthcare in the United States, it becomes a question of, well, where do we start to make cuts? And so, you know, it becomes this question of what's an appropriate utilization of the service at that point in time. And from what we're seeing with emergency rooms sort of emptying out, I just think it's fascinating to think about how we've been taught to utilize our healthcare system and to think about how quickly, really within a month, we've reoriented an entire country away from, you know, perhaps unnecessary visits at times.
Dr. Kowey, anything to add on that one?
Well, this is a really tough one because emergency situations are difficult to interpret without having a full set of tools. So that's the history, the physical examination, laboratory studies. And most people who deal in emergency medicine are very facile with combining these things all together to come to a global assessment of the patient to minimize the chances that you make a mistake in the ER. Remember now, talk about medical liability. I mean, this is like where it really happens. Okay, so they make a mistake in the emergency room, and a lot of bad stuff happens after that. So it's going to be very difficult, I think, for somebody to get on the phone and render an opinion about an emergency situation, especially if they've never seen the patient before, and feel confident in that decision to the point where they tell the patient not to worry. So I'm not really a big fan of that idea. I think our emergency rooms, once this pandemic gets under a little better control, our emergency rooms should be able to handle most of the patients who need to come to the ER. And I'll tell you something that's really scary. I ran into one of our cardiothoracic surgeons this morning in the hallway on my way into the hospital, and he said to me, did you know that over the last week, we had 3 separate cases of people who came in with gigantic heart attacks? I mean, not what we were getting used to is having people come in early, and we open up an artery and we stop the infarct, the heart attack, and the heart attack, the amount of damage that's done to the heart is really, really small. Well, these were 3 that were so big that they blew a hole in the septum, in the ventricular septum. We never see ventricular septal defects from heart attacks. I mean, that became like a zebra. But in the last few weeks, we've had 3 cases of people waiting and waiting and waiting and waiting, having gigantic heart attacks and coming in and being in big trouble. So I think that we have to do the opposite. We have to not discourage people from coming in when they have an emergency, so that we can render care that is definitive and effective. And I think we've gone too far in the direction of telling people to try to stay out of the emergency department. Yeah, I think that's okay under some circumstances, but we have to be very, very careful with that advice.
Megan, next question from the audience.
Sure. Dr. Kowey, just grabbing onto one of the magic words you just said, we do have someone who'd like to know, Do you feel that telehealth carries additional liabilities in regard to medical malpractice as you're getting into this world a little bit more?
Oh, I think there's no question that it does have the potential, at least, to cause more issues. I think part of the issue here is, and we haven't talked a lot about this yet, but it's the experience of the healthcare professional who's doing the telemedicine visit. If you take a very inexperienced person who has not had a lot of time taking care of patients and take an unfamiliar patient that they don't know very well, there is a tremendous opportunity for mistakes. And I feel pretty confident doing telemedicine because I've been doing this for a very, very long time, and I know the patients that I'm talking to on the telephone. I know their circumstances. I know their social situation. I know their spouses. I know the ins and the outs, and I really feel pretty confident that I can give them good advice on the phone. But I'll tell you, there are some situations where this could be the formula for disaster. And as much as people want to line up outside and tell us how wonderful healthcare professionals are, and, fly airplanes over our hospital and stuff, there are still ads on television for malpractice attorneys looking for clients. So this is not a situation I would take lightly. This is something that people have to pay very careful attention to. And if you're a healthcare professional, what I would tell you, what I tell everybody that's worried about medical legal issues is document, document, document. Make sure that whatever you write in the note of that telemedicine visit is carefully crafted and that everybody understands exactly the information that you're transmitting.
Dr. Martin, would you like to add anything to that question?
Yeah, I guess we've seen some of the policies enacted at various state levels that Dr. Kowey mentioned, where you have to have some sort of pre-existing relationship with a healthcare provider before you can seek telehealth services from them. On the positive side of that, right? It fosters this interaction, and that's a really important interaction to have. As Dr. Kowey elegantly explained, it helps reduce risk. The flip side of having that legislative language in place is that it does prevent individuals from seeking care in an emergency situation like we're in right now as well. So I think, for me, from a policy perspective, language that's as open and broad as possible right now is the most useful and beneficial language to have for frontline healthcare professionals.
Yeah, I agree.
Megan, next question.
Sure, and we may be coming up against time here, so I'm going to try to combine as many as I can. We're seeing questions about specific practice areas: physical therapy, psychiatry, optometry, pediatrics. So I guess I'll just ask on their behalf, do you find that there's a space for each of those specialties within telemedicine?
Dr. Martin? Dr. Kowey.
Yeah, let Tom go first. Let Tom go first.
Yeah, I think we kind of mentioned this, that there's going to be different technology platforms for different service lines that are out there. I've seen a couple of questions come in from physical therapists as well. What works for a physical therapist is not going to work for an ICU pulmonologist or an ICU nurse that's got to be, seeing several different things, right? So I think that the technology really depends on, and I've seen a couple of other questions for, recommended or specific platforms. I would say do your due diligence, vet a lot of the platforms that are out there for meeting your workflow and your needs as well. But Dr. Kowey, anything?
I was pretty mystified with Emily's visit. So Emily, how did that go?
I think it went well. I'm fortunate that, I'm in good health, and leading up to that point, everything was running standard, and I would imagine that perhaps if I were in a different situation, that appointment wouldn't have been moved. But I think mitigating the risk of possibly being exposed felt like the better option to stay at home for that visit. But I will tell you, next week I'm going in for a full visit and will be until baby arrives. So I don't know if that was a case by case, and that everything so far had gone well. And like I said, perhaps people in other situations weren't necessarily encouraged to go online for their visit.
I think you hit it right on the head. So you're doing well, you know, and you're going to have a visit next week. So this is sort of like a stopgap, make sure everything's okay, just touch base. You know, the psychological advantage there is tremendous. You know, the patients just love it. They come off, they really believe that it keeps them attached to the system. So, you know, if there just to go through the medicines and talk about what's happening in terms of your, you know, day-to-day routine, very helpful. But as you said, and I completely agree, time for an in-person visit next week, because you can't do all you need to do in an obstetrical visit, obviously, especially in late term, on the phone. And so this is going to be the same thing in every single specialty. There will be situations where we'll be able to do this very, very well on the telephone. There'll be situations where we're going to be kind of laughing. My wife said to me, her gynecology appointment's coming up, and she said to me, now, how in the heck are they going to do that one? And I said, I ain't going anywhere near that. That's not my specialty. But there are situations where it's really going to have to be an inpatient visit or an office visit. And I'm hoping that over the course of the next few weeks that we'll get some clarity on when we can start doing that.
Well, and I know we're running up against a time crunch here. We could probably spend another hour or two on this topic, considering it's so multifaceted. And to conclude today's event, I will ask both Dr. Martin and Dr. Kowey to share any final thoughts. But before that, we are going to encourage our attendees to take part in one more poll. This is poll number 3. After today's webinar, how likely are you to take advantage of telehealth? And while we wait for some results to come in, I do want to thank Dr. Kowey and Dr. Martin again for lending your expertise and insights to today's event, and also to thank St. Joseph's University for hosting today's event. And I'm watching these numbers tick in here, and it looks like right now we have going up to 61% informed as a patient on what to expect. So that looks like they're understanding more of what to expect in these visits. We have 25% empowered as a clinician or a healthcare industry professional to deliver telehealth services. We have 74%, this is our greatest numbers that are agreeing to this statement, confident that I can utilize telehealth if necessary. That's a great number there. 38% interested in exploring telehealth for an upcoming appointment. And right now we didn't have anybody who said that they were unlikely to participate in telehealth unless absolutely necessary. Very fascinating. So again, thank you to Dr. Kowey and Dr. Martin. And what I'll do is I'll toss it to you, Dr. Kowey, first for any final thoughts, and then Dr. Martin.
Well, first of all, the first thing to say is thank you to the St. Joe staff and Emily and the staff, Megan, and Colleen, who worked really hard to get this thing put together. It's terrific. I really enjoyed participating. It's really an opportunity, as you guys have structured it, not only to talk about a lot of the policy issues, and Tom's obviously the expert in that area, but to get into some of the human elements here and to make people comfortable with the idea that, yeah, if you have a good doctor, and I assume you have a good doctor because you should find a good doctor, if you have a good doctor and they're flexible, that this fits in very nicely into the paradigm of how your patient care should go. And encourage people to ask lots of questions to be as informed as possible, but to utilize everything that we have available to keep people healthy through this very, very difficult time. So thanks to St. Joe's for their customary great job of setting it up.
And Dr. Martin, any final thoughts from you?
Yeah, I'm glad that we had nobody that was still worried about using telehealth services after this. Right? We've hopefully converted that 20% that were a little bit skeptical coming into this, or they're at least, you know, mentally prepared. Dr. Kowey, you did a great job talking about the physical, emotional connections that you can have with patients through some of these services, even though we are kind of physically distant. You know, I think things some other questions that we maybe missed that I'll touch on real quick in terms of advocacy or what to do when you have a patient that comes to you that's unhappy. The more that professional societies, professional organizations can work together and I think present a coherent message to policymakers, helps us avoid this mismatch of legislation that's out there where Dr. Kowey can practice into one state but not another, given the pandemic, everything that's going on. I think that's really helpful. Educating patients is also tremendous. I can only imagine with an irate patient that gets a claim denied for a telehealth service and then is on the hook for a certain amount. Having an ombudsman or somebody who can mediate that approach, or navigators of sorts that can help prepare individuals, both providers and patients at the same time, can be useful. And again, I think looking forward, hopefully I'm not teaching from the same slide that I was teaching from back in 2013 that I showed in the discussion. But I mean, technology is quickly changing and evolving. But we've had this capability to do audiovisual interactions for the better part of a decade, probably 15, 20 years, if you look way far back in telehealth services. And I think, it's going to grow, right? It's not just going to be the audio-visual component to it. It's going to be more of the peripheral devices. We saw some questions come in around the Internet of Things. I fielded a couple of questions around platforms and technologies that are out there. These peripheral devices are going to become increasingly important, I think. And as we can use them or deploy them in a way that supports healthcare professionals manage their workflow better, that's a positive for sure.
Well, again, thank you to you both, and a specific thank you to all our healthcare workers across the industry for keeping us healthy and safe, both in these emergency situations, but also in our clinical care during these trying times. A reminder that a recording of this webinar will be made available along with Dr. Martin's slides. We hope you will join us for the next installment of the Unlimited Learning Series on information security, scheduled for Wednesday, May 20th. Check out www.sju.edu/unlimited-learning for the latest updates and upcoming events. Again, I'm Emily Bonney from the class of 2007 and Master's class 2008, and we look forward to next time. Everyone, stay well.